Good afternoon. I told them I didn't believe that 400 some odd people that signed up would be here, but maybe that's because of lunch. So I'm sure more may be making their way in, but it's certainly good seeing each of you. I'm Dr. Kelvin Holloway, the Deputy Executive Director for the Performance and Care Management Office, the Medical Assistance Plan at the Department of Community Health at Georgia. Greatly appreciate being here with you this afternoon as we have some conversations regarding the quality strategy, the 2024-2026 version. I'd be remiss if I didn't at least certainly acknowledge the point person that facilitated the undertaking of developing the quality strategy, along with so many other people, but Dr. Gloria Beecher, who couldn't join us today, led that endeavor, along with so many other incredible persons at the department, subject matter experts, as well as certainly with input from the community stakeholders, as well as Health Services Advisory Group, who is an external quality review organization that we contract with. So certainly want to thank each of them. As you probably are aware, that the quality strategy in of itself serves as a framework and a roadwork that guides the Medicaid agency for the state in regards to how to advance the health status and improve the health outcomes for our members or beneficiaries. Also in terms of it's actually a tool that allows us to establish clear goals and objectives, identify specific metrics and measures that would allow us to track performance, but it's also an accountability tool for our partners that we contract with on the managed care world that facilitate the care delivery for our members. So indeed, it's invaluable. But above and beyond that, we also know that it's a requirement, not only in terms of for us in advance the health status of our beneficiaries, it's a requirement in the federal reg that indeed if you are a state Medicaid agency and you use the care delivery model involving managed care entities, that you must develop a quality strategy and it to be updated at a minimum of every 3 years. And we do that, but it's certainly more than that. It can be more than just a checkoff for a regulatory agency. And in terms of, as I stated, we wish for it to guide our directions. And it also can serve to be a prioritization tool in terms of how we undertake endeavors for our beneficiaries in advancing their health status. What I'd like to do over the next several minutes is to give you some insight in regards to the process that we were engaged in developing and updating the quality strategy, but also in regards to outline the content that has to exist per the regulatory expectation within the document itself, and also finally landing on some key priority populations that are focused and identified by the quality strategy, but also in terms of the goals, the objectives that we reference, and also the management, the ongoing endeavors that will be engaged to facilitate it being a living and breathing document. So as I mentioned, there are some guidelines that are provided by the Centers of Medicare and Medicaid Services in regards to components that must exist within your quality strategy. Certainly given the background of Medicaid in the state, inclusive of shifting to a care delivery model involving care management organizations up to the current state, certainly that needs to be there, but also in terms of SMART goals and objectives that can be tracked and monitored, and what endeavors do you have in place to move the needle on those particular priority areas. Also in terms of the performance improvement projects and initiatives that are planned or expected to be in the document, but also how does the plan speak to addressing disparities, be it in terms of the demographics, race, region. Those are expected to be within the quality strategy for one to be able to follow whether or not one is achieving the specific goals. And by the way, the quality strategy for DCH is on the DCH website under the Performance tab. You can certainly see that one as well as the previous one that we just transitioned from. In addition to that, what are the monitoring capabilities that one has in place for evaluation of how one is achieving that? but also in regards to the accountability tools and standards that one is utilized to actually assess whether the care management organizations are fulfilling the contractual expectations as far as achieving the particular outcomes that are desired and agreed upon. How are you measuring that? Affording opportunity for stakeholders to provide input is expected. Is that captured and conveyed? And also in regards to how do you leverage the resources that the independent external quality review organization, as I mentioned, is HSAC, Health Services Advisory Group. What resources do they bring to bear? And also are those deliverables that are also mandated by CMS that must exist and must be accomplished by an external quality review organization. PIPs, performance improvement projects, compliance reviews of the CMOs, also in terms of performance measure validations and network adequacy, all expectations that CMS has of an external quality review organization. All of that is expected to be in the quality strategy per CMS. This just speaks to the logic model. I apologize. I was instructed, but I need to shift my screen to see a little bit better. My apologies. So the logic model that was utilized in terms of the construction or the development of the quality strategy. So what are the inputs? Well, certainly a review of the landscape in terms of what exists in the external community as far as data, as far as outcome data, as far as quality of life data, as far as beneficiaries and for the state, what resources are available not only within DCH but elsewhere, sister agencies, other systems, federally qualified health systems, centers rather. You look at all of that information as far as input, as far as helping us and guiding us. We also certainly rely upon the prior quality strategy and the particular outcomes, what was achieved and what was not, so that one can construct the quality strategy that does exist now. And the outputs of that in terms of ultimately would allow you to think through how best to integrate services so there's not duplicate. Where's there synergy? How can you prioritize not only what you hope to achieve, but also resources, people, taxpayer dollars, such that one can achieve the particular outcomes that one desires. Ultimately, in terms of short-term goals and gains, in terms of moving the needle towards advancing to the particular goals that are desired from a population health basis, but also in terms of the short progress that can be evidenced, be it through process measures. We'll talk a little bit more about that versus those lag measures that are going to take a little bit more time to achieve. So we want to be able to track that, and ultimately, over a period of time, these strategies should evolve over time to be a continuum such that you can continue to advance and look at it as more of cycles of advancing than just a static document. And that's what you would like to be able to evidence as you track the progress of the particular metrics that are actually noted in the quality strategy. The actual, somewhat of an, not quite the components of the quality strategy are noted here, starting with the expectation that the purpose of why this is actually being done, the scope and goals of the strategy itself are noted. Background, as I mentioned a little bit earlier, as far as the expectation and the structure within Georgia Medicaid, how is the state structured to be able to oversee what's planned, be it what's spoken to in the quality strategy, and also in regards to how do you plan to not only develop it, but review it and refine it as you go. That actually has to be spoken to and thought of as you are creating the document. In addition, what quality assessment and performance improvement program do you have in place within the state that also actually oversees and interacts with the CMOs who also have the expectation contractually to have a QAPI program in place? How do you evaluate that program on an ongoing basis in terms of achieving the particular goals that are stated in the CMO plans? What structure is in DCH and the medical assistance plan to oversee that endeavor? And the oversight and governance of the quality strategy is essentially what we're speaking to, and other standards that are to ensure access, quality outcome, and timeliness of the care. Do you have the capacity and the bandwidth within the state, within the Medicaid agency to oversee that for what the CMOs are responsible for, but also the components that are still within fee-for-service to a lesser extent? And then also there are the appendices that exist within the quality strategy. Again, as I stated, if you wish to view the current quality strategy, the 2024-2026, it is on DCH's website. It speaks to in terms of the quality strategy as it is and how it makes a crosswalk to CMS regulatory expectation. That crosswalk needs to be there. Also in terms of the metrics that have been identified that will be tracked over a period of time, and the PI endeavors that are planned, but understand that's not static, and that can be updated on an ongoing basis as initiatives arrive on an annual basis such that it can be updated. Also in terms of a tracking table to be able to see how one is moving in the progression of advancing toward the particular goals that are established. And also each year, the External Quality Review Organization, as I mentioned, Health Services Advisory Group is the entity that the state uses. There's an annual technical report that's required to be submitted and placed on our website by April of every year. That actually captures the work and the endeavors of all the deliverables from the CMOs on an annual basis, and that particular compilation, be it for the evaluation of the past quality strategy, is also there. And just how effective was the past quality strategy, that is a component of the current quality strategy in its appendix. I make note here that because the data that is utilized to evaluate the effectiveness and whatever, there's a lag period using NCQA metrics, HEDIS metrics, there's a lag period. So we will be closing out the evaluation of the prior strategic plan this quarter from the data that's just coming in. So then we'll be able to close that out as far as evaluating. And just to date, there were about 24 goals that were noted in the prior quality strategy, and about 10 of those were achieved. Some of those rolled over to the current one. There were some additions, some deletions based on measures that may still be present or not, but applicable measures were identified that aligns with the particular goals that were identified for the 2024-2026 quality strategy. Also, there was an expectation and certainly invaluable input, not just from internal stakeholders within DCH, but certainly the Managed Care Committee of the Board, the Medical Care Advisory Committee, as well as opportunity for public comment, as well as other sister agencies provided input and perspectives as pertains to the goals and objectives, the actual strategies, the metrics, all of the above that are noted here. We sought input from multiple stakeholders, internal and external. Now, out of all that input, and I think you saw Commissioner Portman earlier, not Commissioner, but Executive Director Portman earlier this morning made mention of priority populations that were identified. And the 3 priority populations that were identified and are a linchpin of our particular quality strategy are improving outcomes for chronic diseases, specific chronic diseases. We'll talk a little bit more about those when we look at the goals themselves and the objectives, and also improving maternal and newborn outcomes and improving behavioral health care outcomes. We develop a visualization model within the MAP division in DCH where we speak of pillars, and the 4 pillars that we lean upon and connect the particular goals and objectives to are access. How do we drive care that's equitable and accessible? How do we improve the quality for our beneficiaries or our members? How do we improve the experience for our members across the board? And how do we be good stewards of taxpayer dollars? Prioritization of resources based on the priority areas is really what we're speaking about. So we try to connect the goals and objectives, particularly the objectives, with the particular pillars. You probably can't see that. I apologize. But what we wanted to do, there are 7 actual goals that are noted in the plan, and also specific objectives that are connected. Now, I think I always want to be able to share that this is not stagnant, but it's a starting point, understanding that the goals are there, and while we do have the specific objectives that are connected to it that are indeed measures that would allow us to track how well one is performing and as relates to those particular objectives, We understand as far as the CMOs as well as others, there are a plethora of measures that are looked at through the course of the time period. These are just select ones, but we do look at and monitor and track a number of metrics that may be related to these or related to other things that are a priority and importance as well. But as far as what's in the document itself, these are the particular objectives that are noted here. And I won't read through them, but it's more so from the standpoint as far as access, particular measures that can give you as a proxy that if they are achieved, in other words, well-child visits or wellness visits, it allows you to assume if those things are occurring, that access is taking place. And we understand that there are some assumptions there, but that's how the metrics are being utilized, that if those measures are performing well, 50th percentile, 75th percentile, and so forth, one can make the assumption that members are accessing care in order to achieve that. Same thing as relates to wellness and preventive care. Some key metrics that will allow us to understand whether or not our managed care organizations are able to achieve the appropriate immunizations, the appropriate assessment of healthy lifestyles as far as weights and so forth, in terms of appropriate screenings. These are endeavors that we want to keep an eye on, in addition to others, but certainly these and track the progress of whether indeed wellness and prevention care is provided in the fashion that we think that it should based on benchmarking. We mentioned in regards to the outcomes, be it for chronic disease, specifically high blood pressure, diabetes, certainly in terms of asthma. These are measures that we are looking at along with our CMOs to track whether or not how well we're doing. Understand this does not in the document doesn't speak to the how, but it does speak to in regards to what we're looking at to see indeed if we're trending in the appropriate way to address the noted goals that are here. Also, finally, next you see in terms of goal 4, maternal outcomes and newborn care, particular measures again, prenatal care, postnatal care, in terms of substance use disorder and so forth, in terms of during pregnancy and postpartum period. Particular measures that will give us insight into the care of the mother and the baby will allow us to be able to track our progress toward this particular goal. Probably the only one here that speaks to an outcome measure, that's a lag measure, is in regards to the birth weight, 2,500 grams, and decreasing that. Everything else, when we think about it, keep in mind, most of these are process measures in terms of upstream measures. They, again, you make some assumptions that they are taking place. It will lead to the particular outcome that one wants to achieve. There are a number of measures here related to behavioral health. Again, it's kind of a plug and chug. These are behavioral health measures that do exist, be it in the HEDIS world or the Corset world, as far as CMS is concerned. So we use those in order to track. A number of assumptions are made, as I said earlier, that if you see improvement in regards to follow-up care, preventing 30-day readmission from hospitalization, these are measures that we look at in order to see, again, are we progressing to the behavioral health outcome of improving outcomes in general. And then finally, the other two are related in terms of stewardship, in terms of resource utilization, or persons receiving the care in appropriate settings, preventing readmissions, preventing utilization of the ED. One makes assumption that those things are occurring, that appropriate connections, transitions of care, and so forth are taking place as they should, thus appropriate utilization of resources. And finally, what's the member's experience? You know, are we moving in the right direction as pertains to the CAP scores, as far as how members are rating their experiences? That's important, right? This just kind of gives a sense of the timeline of that progress that process that we just referenced. It was probably a year-long, not quite a year-long process that we were engaged in, ultimately resulting in the submission of the document to CMS first part of June and receiving feedback from them a couple of months ago that it was accepted. So it's live and well and approved by CMS, and as I mentioned, it's on our website where you can review. I encourage you to actually go to the site to take a look at it at your leisure. But I think it's important that we don't just stop there. Those of you that are into performance improvement and so-called gurus or geeks for that, if you're not, it's okay, it's okay. But you are an improvement. If you're in practice, you're an improvement whether you acknowledge it or not. How do you improve your practices? Your operations, your clinical outcomes, you are an improvement. So it's important. We listed a lot of things as it pertains to goals and objectives of measures. But you really don't stop just at the monitoring, performance monitoring. You really want to shift into the performance management aspect. And it's the management of performance that you really speak to. And one thing that we are engaged in each one of those priority populations that we identified, be it in terms of maternal outcomes, newborn outcomes, be it in terms of behavioral health and chronic disease, we're developing a strategic approach for each one of those populations. I mean, what's out there in the community, white paper-wise, literature-wise, that evidence, the strength of that evidence, that these things make a difference. These things will result in improving the outcome in the particular populations. And quite often, it's not just one silver bullet, it's probably multifactorial. You don't improve maternal health with just one undertaking. It's things on the policy side, it's things in terms of clinical practice, it's actually in terms of outreach. It's a multitude of things that have to be put in place. And what are those things, and what's the strength of those activities? We want to be able to say the things that we're putting in place in collaboration with our CMOs makes sense and is evidence-based. That's what this is about in regards to speaking to the strategy for the priority populations. And then what are the measures that we're using to actually not just track progress to the goal, but tracking those undertakings that we've identified that will make a difference. That's the performance management aspect. And it's okay if some things don't work, because that's part of performance management. How do you have the conversations about tweaking that? And it's okay that we understand that to improve these outcomes, it's not a one-year endeavor. It's not a two-year endeavor. It's the long haul. And it's a never-ending journey. Performance improvement, performance management never ends. So you have to be committed to a cycle of improvement. And what this is about is in regards to being able to have the conversations with your managed care partners, with your providers, in regards to what can we adapt, what can we change? If one cycle of improvement didn't advance the way we wanted to, do we need to change things? And it's okay that if, I'm gonna qualify okay, there is an expectation you're accountable for improving the outcomes, right? We're accountable for that. The reality is you will not see that outcome improved in the short term, but can you evidence progress toward that, be it in terms of examples of change, small test of change? Is it in a provider's office that you're testing that, and that it can be spread from there to a region, to a population, rural area? That's not going to show up in the big dot or the big measure, but if one is evidencing that's making progress, and now we're ready to spread and the resources can be prioritized, that's what the strategic plan ultimately wants to get to. That's the management aspect of it that we want to. But not only that, what are the accountability tools that are in place? There needs to be accountability tools in place. What are the venues that we can report out on how well we're progressing? What are our conversations that we're having with each other, the CMOs by themselves, but also collectively? Mutual accountability in regards to progressing for the good of the benefit of the beneficiaries and the members. The public-facing dashboards that compares outcomes, accountability tools. We need to put those in place so the public and all stakeholders can be aware that their resources are being applied in an appropriate fashion. That's performance management. Are there alternative payment models that might advance this? Pay for performance, pay for outcomes. The direct payment programs that are in place now, and you heard Executive Director Portman speak to. Those are endeavors that looks at alternative payment models, and there's evidence out there in the country as well. I mean, the literature speaks to what extent it really improves outcomes, but you do know there are cost savings as well as incentives in terms of improving the actual performance management aspect of it. Then there's certainly the contractual expectations, be it with the CMOs, in terms of the accountability venues and discussions that one has in regards to that, and also the evidence-based policies that I made mention of. You know, some of that is in terms of from DCH's perspective, legislative-wise, and so forth. You know, how do we ensure that policies that are put in place will address this? We often talk about opening up this code, right? opening up a payment code where that's policy. And is there evidence that doing so will make a difference in the particular areas that we are trying to advance? And sometimes you have to make prioritized decisions, right? I think, I started to say regrettably, I guess I just did. It's sometimes challenging when you receive various requests and so forth, and ideally you would like to be able to look at those things in a collective fashion to prioritize your responses of where it fits neatly. Well, one thing the quality strategy should do, I think Stuart Portman earlier today talked about 50 some odd things that we have going on and so forth. How do you prioritize your attention and your priorities? How can you refocus on what's important? All 54 of those things are important, so don't quote me that they're not important. That's not what I'm saying. But as you do those things, how do you refocus such that when you get to the end of the year or 2 years, you've advanced something strategically? That's what the strategic plan is to be used for. You still have to do the urgent things, but the strategic plan and the prioritization should allow one to come back and refocus for something that's strategic in nature. And that's how we really want to leverage the strategic plan. So I'll stop there. I know we didn't use the full hour. I know you're not complaining. But I'll stop and certainly answer any questions or even comments if you have any.
Well, this seems like this is somehow related to the HCBS. Is there any correlation? I know that both of them probably are mandated by CMS, but is there any correlation between the two?
Thank you for your question. Not a direct correlation as far as the home and community-based service, that population. That is a population that is still would be considered fee-for-service. However, our quality strategy, even though it's mandated, be it for the MCO, CMO population in the managed care world, it does encompass, from our perspective of how we drew it or developed it, the fee-for-service population as well. So there are efforts and energy to develop appropriate measures. Matter of fact, going forward, there is an expectation that you will track or do caps for that population as well. For any member that's in a Medicaid offered plan, you would do a cap, or you certainly should still monitor them as well. So I don't know if that answers your question.
It does. So
Okay.
They said that we were leading up to being ran through managed care within the next 2 to 3 years. And I don't think it's going to be DBHGD, but a lot of the elderly and disabled waiver programs, if not all, will be housed under managed care as opposed to fee-for-service. So I guess this is helpful information just to kind of see how it's being done through managed care right now.
Yeah, I mean, no, you are right. The current procurement that's still out there in regards, some of the age blind and disabled population will shift over into managed care. So certainly, just as we've done this now to include some of the fee-for-service population which oversees that, it would still be applicable. Just some of the context and the actual substance of the plan would probably be edited and updated some to reflect it being in the managed care arena as far as the care delivery model. Right. Any other questions? Has to be one more. Yes.
Can you share any preliminary data for the 2023?
I guess not so much the actual data, but it was, as I stated, the actual goals themselves. There were, objectives. There were 24 measurable objectives in the 2021 to 2023. As I mentioned, there were 7 of those goals that were achieved in the last quality strategy. There were 3 that were within range of being achieved. We really won't know that until this quarter, as I said, with the particular data that's now been finalized, because as I shared the data is lagged because of how it comes in. The 2023 is being closed out this quarter from information that just had come in. So I can speak to it from that standpoint of the number of goals that were achieved, but it's actually available. I would encourage you to take a look at it from the standpoint of the documents that are present on the website. Is that helpful? How often is the data shared with the CMOs? So a couple things, let me speak to it, and thank you for your question. We have a quality oversight committee meeting that's been in place, that we have meetings with the CMOs. We do it with them now individually, but also collectively to a lesser degree throughout the year. And we have a measurement list that we look at. It certainly includes a good number of the measures that are noted in the quality strategy, but there are additional measures that we look at as well with them. And they are tied to the pillars that we spoke about, those 4 pillars: the quality, access, stewardship, and the service experience. And we have conversations with the CMOs where they actually discuss the data, opportunities, initiatives that are in place, or tests of change that they may be engaged in. So we do have those conversations on a regular basis. But also, the CMOs, through their accreditation process, also receive, as I said, they're measuring a number of measures that are NCQA measures, HEDIS measures, a large number of measures, much more even robust than what we've pulled out for the quality strategy or what we track, that they actually are utilizing and actually rated on as well, that we are aware of and look at as well. So yes, we do have conversations and share that with them. But also there is a dashboard. It's been cleaned up. It's going to be reposted, but the initial post took place maybe 3 years ago. It's been down for about 8 months now. I'm looking forward to go back with a new version in about maybe a month or so. And it's actually where it's public facing. It's public facing, where you can look at comparison of the CMOs on a number of quality measures in terms of actually also track the trends over a 3-year period and see how they're responding, comparing it to each other, but also in regards to benchmarking as well.
Thank you, Dr. Holloway.
Oh, that's it? Well, thank you.
I have a question, but I want to
Okay,
say
no, I'm
thank
sorry.
you
Go
for
ahead.
updating the dashboard.
Okay. I'm sorry?
Thank you for updating the dashboard.
Okay.
And I do have a question, but I wanted to make sure the gentleman is done.
Yeah, I think he is.
All right. So as it relates to the populations of focus, maternal infant health, behavioral health, et cetera, can we pull in providers, maybe the OBGYN Society, maybe the Pediatric Society, et cetera, to help us move Georgia along faster?
Most definitely.
progress.
Most definitely in collaboration with all the stakeholders to be able to advance that. As I said, it's not just one magic bullet. So it actually is going to have to be interfacing, certainly leveraging the CMO and the resources they bring to bear, interacting with their physician panel as well, but also directly interacting with the physician, how we can incentivize them, their incentive plans, be it through the CMOs, as relates to connecting those priority areas, specific measures, and how they're incentivized through the CMOs, be it for those measures. And I don't know if the CMOs talked to some of those incentive programs earlier in the day or not.
We did.
Okay.
Yes,
okay.
we did.
Yeah, so that's certainly one way in which we acknowledge the actual capability, but also the direct physician payment program, which also is funneled through the CMOs, but those are additional resources that are brought to bear that CMS requires to be connected to the quality strategy.
Awesome.
So we are leveraging resources to be incentivized, but also the interactions that you and the other leaders from the CMOs interact with the panel, physician panels, to advance them, certainly.
Awesome. Thank you.